This is Lecture 06, Airway, Rapid Sequence Intubation, and Ventilator Emergencies. The emergency airway is not just a tube placement procedure, it is a resuscitation procedure. The goal is to oxygenate, ventilate, protect physiology, and avoid peri-intubation collapse. The objectives are these. First, identify who needs an airway now versus soon. Second, predict the difficult airway using bedside tools. Third, pre-oxygenate and optimize physiology before rapid sequence intubation. Fourth, choose induction and paralytic medications with ED logic and dose to physiology. Fifth, recognize and treat peri-intubation hypotension, hypoxia, and acidosis. Sixth, set lung protective ventilation and adjust for obstructive disease and ARDS. And seventh, troubleshoot the crashing ventilated patient using DOPES. Intubation is a physiologic stress test. The question is not only whether the tube goes through the cords, the question is whether the patient survives the attempt. Think anatomy, oxygenation, and hemodynamics. The best first-pass success is oxygenated, perfusing, first-pass success. The peri-intubation killers can be remembered as HOP, hypotension, hypoxemia, and acidosis. Hypotension before or during induction predicts arrest. Hypoxemia means oxygen reserve was inadequate or the patient deteriorated faster than expected. Acidosis means the patient was already compensating with hyperventilation, and apnea during induction worsens the pH catastrophically. Treat these before the tube. Pressors for hypotension, aggressive preoxygenation for hypoxemia, and either delayed sequence intubation or accelerated minute ventilation for acidosis. The airway decision is built around 4 questions. Can the patient oxygenate? Can the patient ventilate? Can the patient protect the airway? And what is the anticipated course? A patient who cannot oxygenate, cannot ventilate, cannot protect, or is predicted to lose the airway needs early action. Do not wait until the airway is completely lost. The board principle is to act on trajectory, not just current status. Difficult airway prediction in the ED is imperfect, but it changes planning. The lemon mnemonic covers: look externally, evaluate 332, Malampati, obstruction and neck mobility. 332 means 3 finger breaths between incisors, 3 finger breaths from chin to hyoid, and 2 finger breaths from hyoid to thyroid notch. The MACOCHA score predicts difficult intubation in the ICU and emergency department, weighing factors including Malampati class 3 or 4, obstructive sleep apnea, reduced cervical mobility, limited mouth opening, coma, severe hypoxemia, and non-anesthesiologist operator. The point is to plan A, plan B, and plan C before induction. Plan A is the tube. Plan B may be supraglottic ventilation. Plan C may be a surgical airway. Know the parallel mnemonics for boards. Moans predicts difficult bag mask, mask seal, obesity or obstruction, age greater than 55, no teeth, and stiff lungs. Rods predicts difficult supraglottic device, restricted mouth opening, obstruction, distorted anatomy, and stiff lungs. Short predicts difficult cricothyrotomy, prior surgery, hematoma or infection, obesity, radiation, and tumor. Cormack-Lehane grading scores the laryngoscopic view from grade 1, full cords visible, to grade 4, no glottic structures seen. Grade 3 or 4 predicts difficulty and prompts a video laryngoscope. Bougie, or supraglottic rescue. Preoxygenation buys time. Use a non-rebreather, high-flow nasal cannula, non-invasive ventilation, or bag mask ventilation with PEEP based on the patient. Goal: 3 minutes of tidal volume breathing or 8 vital capacity breaths if time is short. Apneic oxygenation with nasal cannula at 15 liters per minute should stay on during the attempt. The buzzword is no DSAT, meaning nasal oxygen during effort securing a tube. Leave the cannula on throughout paralysis and laryngoscopy. Position the patient well, with the obese patient ramped so the external auditory meatus aligns with the sternal notch. Oxygen reserve is finite. In a healthy adult, apnea time before desaturation can exceed 5 minutes. In the obese, septic, or critically ill patient, desaturation begins in well under a minute. Hemodynamics are where patients die during intubation. Treat shock before induction when time allows. Use norepinephrine drip or push-dose pressors when hypotension is imminent. Push-dose phenylephrine is 100 micrograms intravenously every 2 to 5 minutes. Push-dose epinephrine is 10 to 20 micrograms intravenously every 2 to 5 minutes. Give crystalloid or blood when appropriate. Positive pressure ventilation reduces venous return, so be cautious in severe hypovolemia, tamponade, and right ventricular failure. A pre-intubation shock index, defined as heart rate divided by systolic blood pressure, greater than 0.8 should raise concern. The standard induction agents in the emergency department are etomidate, ketamine, propofol, and midazolam. Etomidate is 0.3 milligrams per kilogram intravenously. It is hemodynamically neutral in most patients, with rare concern about adrenal suppression after a single dose, the classic ITE buzzword being transient cortisol depression in septic shock. Ketamine is 1 to 2 milligrams per kilogram intravenously or 4 to 5 milligrams per kilogram intramuscularly. Ketamine supports blood pressure and bronchodilates, making it a favored choice in shock, severe asthma, and anaphylaxis. The board distractor is the sympathetic surge. Avoid ketamine in severe uncontrolled hypertension, aortic dissection, and elevated intracranial pressure in the hypertensive patient. Propofol is 1 to 2 milligrams per kilogram intravenously, with dose reduction in shock because it drops blood pressure. It is preferred in the hypertensive patient or the actively seizing patient. Midazolam is rarely first line for RSI because of slow onset, blood pressure drop, and unpredictable hemodynamics. The principle is to dose to physiology, not to habit. In shock, reduce the induction dose by roughly half and double the paralytic dose. Rocuronium versus succinylcholine is a classic debate. Rocuronium is 1.2 milligrams per kilogram intravenously with onset in about 60 seconds and duration of 40 to 60 minutes. Reversal with Sugamadex is possible if available. Succinylcholine is 1.5 milligrams per kilogram intravenously with onset in about 45 seconds and duration of 5 to 10 minutes. Avoid succinylcholine when hyperkalemia risk is elevated. The classic ITE list is burns greater than 24 hours old, denervation injuries such as stroke or spinal cord injury greater than 24 hours old, crush injuries, chronic neuromuscular disease such as muscular dystrophy or ALS, rhabdomyolysis, known hyperkalemia, and personal or family history of malignant hyperthermia. Within the first 24 hours after a burn or denervation event, succinylcholine is still safe. The hyperkalemic response develops as upregulated extrajunctional receptors mature. Both achieve excellent intubating conditions. In shock, the higher rocuronium dose maintains rapid onset despite low cardiac output. After intubation, the work is not done. Confirm tube placement with waveform capnography, which is the gold standard. Check chest rise, breath sounds, tube depth at the teeth, and chest x-ray when stable. Start analgesia and sedation immediately if a paralytic was used. Fentanyl 1 to 3 micrograms per kilogram per hour for analgesia, propofol 20 to 50 micrograms per kilogram per minute, or ketamine 0.5 to 2 milligrams per kilogram per hour for sedation. Set lung protective ventilation. Reassess blood pressure and oxygenation. Then look for complications. Right mainstem intubation, pneumothorax, and aspiration. The most common cause of post-intubation hypotension is positive pressure ventilation, reducing preload combined with sedation-induced vasodilation. Treat with a fluid bolus, dose reduction of sedation, and push dose pressors if needed. Always recheck the tube before chasing pressors because right mainstem intubation and tension pneumothorax mimic the same picture. Initial ventilator settings should be deliberate. Volume assist control is the common ED mode. Tidal volume is 6 to 8 milliliters per kilogram of predicted body weight, lower in ARDS at 6. Predicted body weight is based on sex and height, not actual weight. Respiratory rate is 12 to 16, adjusted for ventilation needs. Start FiO2 at 100%, then titrate down to oxygen saturation of 92 to 96%. PEEP starts at 5 for most patients, higher in ARDS. Watch the plateau pressure. Keep below 30 centimeters of water to avoid barotrauma. Driving pressure, defined as plateau minus PEEP, should be kept below 15. The board concept is pH-driven minute ventilation. A patient intubated for severe metabolic acidosis, like DKA or salicylate toxicity, was compensating with hyperventilation, so set a higher respiratory rate and accept a higher minute ventilation to match the pre-intubation pH. Underventilating these patients is a classic distractor that causes peri-intubation arrest. The crashing ventilated patient gets DOPES. D is displacement of the tube, O is obstruction of the tube, P is pneumothorax, E is equipment failure, S is stacking, also called auto-PEEP or dynamic hyperinflation. The first move is to disconnect from the ventilator and bag the patient with a self-inflating bag. If the patient improves off the ventilator, suspect ventilator settings or breath stacking. If the patient does not improve, work through the differential. Check tube position, suction, listen, and consider needle decompression for suspected tension pneumothorax. The classic distractor on the boards is the crashing asthmatic on the ventilator who is harder to bag. The right answer is disconnect from the vent and allow exhalation to relieve auto-PEEP, not give more pressors or increase the rate. Asthma and COPD ventilation is dangerous because the patient needs time to exhale. Use a lower respiratory rate, around 10 breaths per minute. Use a high inspiratory flow, around 80 to 100 liters per minute, to shorten inspiratory time and lengthen expiratory time. Accept permissive hypercapnia with pH down to roughly 7.2 if needed. Tidal volume around 6 to 8 milliliters per kilogram. If the patient becomes hypotensive or difficult to ventilate, disconnect the ventilator and allow exhalation for 30 to 60 seconds. Breath stacking can cause hemodynamic collapse from compressed venous return. ARDS requires lung protection. The board buzzword is ARDS net. Tidal volume 6 milliliters per kilogram of predicted body weight, plateau pressure below 30, and a PEEP FiO2 ladder. Tidal volume is 6 milliliters per kilogram of predicted body weight. Plateau pressure must stay below 30 centimeters of water. Driving pressure should stay below 15. Use a higher PEEP and FiO2 ladder, often guided by the ARDS net table that pairs increasing PEEP with increasing FiO2. Permissive hypercapnia is acceptable. Avoid chasing a perfect oxygen saturation with injurious pressures. Severe ARDS may require neuromuscular blockade, prone positioning, and ICU level support. The board concept is that lung protective ventilation saves lives, even at the cost of hypercapnia. The failed airway algorithm is a sequence, not a panic. If you cannot intubate, but you can ventilate with bag mask or supraglottic device, you have time. Reposition, reattempt with a different approach, or call for help. If you cannot intubate and cannot ventilate, this is a cannot intubate, cannot oxygenate situation, and surgical airway is indicated immediately. Cricothyrotomy is the rescue. A horizontal incision through the cricothyroid membrane, dilate, and pass a 6 or 6.5 endotracheal tube. Bougie-assisted cricothyrotomy and scalpel finger bougie are widely taught techniques. The board concept is that hesitation kills. Recognize the failed airway and act. The airway board traps are common and predictable. Forgetting preoxygenation, using standard sedative doses and shock, paralyzing with rocuronium and forgetting post-intubation sedation, leaving the patient awake and paralyzed, missing right mainstem intubation or pneumothorax, overventilating an asthma patient and causing auto PEEP collapse, calling the tube successful before waveform capnography confirms it, and failing to recognize the failed airway and proceed to cricothyrotomy. Another tube attempt is the wrong answer in the failed airway. Case 1. A 64-year-old septic patient is hypoxic, confused, and hypotensive with a systolic blood pressure of 85. The airway is needed, but physiology is dangerous. Preoxygenate aggressively with bag mask plus PEEP or non-invasive ventilation. Start norepinephrine before induction. Give a crystalloid bolus if appropriate. Reduce etomidate or ketamine induction dose by roughly half. Use a slightly higher rocuronium dose. Have push dose pressors ready. This is resuscitation before intubation. Case 2. A patient intubated for status asthmaticus becomes hypotensive with high peak pressures and poor ventilation. Think breath stacking. Disconnect the ventilator and let the patient exhale for 30 to 60 seconds. Then reduce the respiratory rate, increase inspiratory flow, and allow permissive hypercapnia. The trap is giving fluids and pressors while missing auto PEEP. Continue bronchodilators, magnesium, and consider ketamine or volatile anesthetic for severe refractory bronchospasm. Question 1. A post-intubation patient suddenly desaturates and has absent left breath sounds. What are you worried about? Right mainstem intubation and pneumothorax are high on the list. Reassess tube depth at the teeth, capnography waveform, chest exam, and bedside ultrasound or chest x-ray. The trap is calling the tube successful without serial reassessment. Question 2. An intubated asthma patient becomes hypotensive with high airway pressures. What is the next best step? Disconnect the ventilator briefly and allow exhalation for 30 to 60 seconds. Then reduce the respiratory rate to allow expiratory time. Increasing the rate worsens auto PEEP and can cause arrest. The board principle: in obstructive disease, slow the rate and let the patient exhale. Question 3. Rocuronium was used for RSI and the tube is confirmed by waveform capnography. What must be started immediately? Analgesia and sedation. The trap is leaving a paralyzed patient awake because paralysis outlasts the induction medication. Use fentanyl plus propofol or ketamine. Individualized to the patient. The final takeaways are these. The emergency airway is a resuscitation procedure. The peri-intubation killers are hypotension, hypoxemia, and acidosis. Preoxygenate aggressively. Apneic oxygen during the attempt. Optimize hemodynamics before induction. Use push-dose pressors or norepinephrine when needed. Dose induction agents to physiology, not habit. Confirm tube placement with waveform capnography. Set lung protective ventilation with tidal volume 6 to 8 milliliters per kilogram of predicted body weight. When the ventilated patient crashes, run DOPES with auto PEEP high on the list in obstructive disease. Recognize the failed airway early and act. Bagging harder is the wrong answer in the crashing asthmatic on the vent. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the Difficult Airway Society Guidelines, the ARDS NET Trial, and successor lung protective ventilation literature, Walls and Murphy's Manual of Emergency Airway Management for procedural detail, the Sepsis PAM, and other peri-intubation hemodynamic trials, and local institutional airway protocols. Cricothyrotomy techniques are based on scalpel finger bougie and bougie-assisted approaches as currently taught.